there are data showing that there are genomic abnormalities in patients with Waldenström's, and there are two that have been more popular. One of them is the MYD88 mutation. We have known about this mutation from our center since 2012. The WHO just included that finding in lymphoplasmacytic lymphoma in 2016. So it took about 4 years to be able to make this a mainstream issue. We described also a second mutation seen in about 40% of patients with Waldenström's in a gene called CXCR4. It's a gene that has to do with homing of cells into the bone marrow. And we described that in 2015. So more and more, we're actually learning about this second mutation. The MYD88 mutation helps us diagnose Waldenström's. I think if somebody in the right context have an MYD88 mutation, the diagnosis of Waldenström's is fairly certain. It can also help us decide which treatments to use. There are some treatments in which would not work as well if patient does not have an MYD88 mutation, ibrutinib being one of those examples. CXCR4 mutations, so far we know, there have been few studies on this, is showing that the clinical aspects might be a little bit different. These patients tend to have a higher burden of disease in the marrow. They tend to have higher levels of IgM, and also can actually be associated with a higher risk of hyperviscosity. We were just talking about that. So this is what we think it's important. Now, in terms of treating with ibrutinib, CXCR4 mutations seem to affect adversely the outcomes of these patients. Specifically in the time to reach a response is a little bit longer on these patients. The depth of the response is not as good as the other patients without CXCR4 mutations. And we have data now showing that the duration of that response might actually be shorter as well. So I think the treatment of patients with CXCR4 mutations with BTK inhibitors like ibrutinib, we need to be very careful about that and consider sometimes other options in that setting. There have been a number of studies trying to evaluate risk factors for the survival of patients with Waldenström's, and it's really difficult to ascertain. Most studies, and the classic index that we use is the IPSS-WM, or the International Prognostic Scoring System for Waldenström's macroglobulinemia. That study was done several years ago, and more than 95% of the patients got treated with just chemotherapy without the new agents that we have. So in that study, we used 5 factors. We used age, we used hemoglobin, platelet counts, beta-2 microglobulin, and serum IgM levels to kind of decide which patient is going to do better or worse down the road in terms of survival. The downside of that is that is taken specifically when the patient starts treatments. And most of our patients have had few to several years between diagnosis and starting that treatment. So at diagnosis, we really don't have good prognostic factors. I think the most important in my experience is age. Patients who are diagnosed at a younger age tend to have a longer survival, and patients who are diagnosed at an older age have a shorter survival, but that's life up to some degree. So the IPSS-WM is helpful once we start the first treatments. So what we're measuring after IPSS-WM is not really overall survival, it's actually survival after first treatment initiation. And that's what we need, is very important to understand, which is different than the other factors that we tend to use in patients with lymphomas. It's important also to realize the prognostic value that mutations can have in Waldenström's macroglobulinemia. For example, patients without MYD88 mutations, which is about 10% of our patients, do have a worse outcome, and they tend to have a higher risk of transforming into more aggressive lymphomas, for example. On the other hand, CXCR4 mutations do not seem to affect the overall survival of patients, but it does seem to affect how they respond to some treatments, and one of them is ibrutinib. As we described previously, these patients have shorter responses, and they have more time to actually get into a response. So there are some value of actually identifying these mutations. I acknowledge that it's difficult for a community oncologist to actually get access to a CXCR4 mutation testing. We do it in our center because we have the resources and we can do it. So my sense is, if we are thinking a patient is a candidate for a BTK inhibitor, then probably that's a good time to actually look for a CXCR4 mutation. However, if the patient is going to be treated with rituximab-containing regimens or chemotherapy or other agents that are not affected by these mutations, then it might not be the right thing to do. upon reviewing this case, the IPSSWM scoring is about 2 out of 5, which puts this patient into an intermediate risk category. And again, I want to remind everybody that this study, the IPSSWM, was a study done years ago in which patients were treated with chemotherapy. There was a study, more recent study, in which validated that same scoring system in patients treated with rituximab-containing regimens. We don't have any data really to suggest that the IPSSWM is predictive in patients getting treated with BTK inhibitors. So this is data that we're going to be collecting. In our database, we have about 300 patients in my clinic on BTK inhibitors at this time. So we want to be evaluating this very shortly when we have more follow-up.